interstitial nephritis or TIN. Basically, it is the inflammation of the interstitial, the area of the kidney that is called interstitium. So, when the inflammation takes place in the interstitium, that is called interstitial nephritis. So, in interstitium, the things which are present, these are the cells, extracellular matrix, and fluid surrounding the renal tubules. Interstitium participate in the fluid and electrolyte exchange as well as endocrine functions of the kidney. The endocrine kidney functions are the activation of the vitamin D, active form of vitamin D, that is called 125 dihydroxycholecalciferol, and the production of the erythropoietin hormone. So patient does not experience anemia, and renin secretion. So this is the endocrine function of the interstitium. There are various contributing factors that leads to this TIN, the pharmacological agents, environmental, and there are acute infectious disease or chronic inflammatory disease, systemic disease. These are all contributing factors that affect the interstitium, so they cause the interstitial nephritis. So, spectrum of the disease presentation can range from the acute process to chronic condition. With progressive tubular cell damage and renal dysfunction. So, presentation depend upon either acute or chronic. Patient can present with the acute phase or in the chronic phase. This slide shows the etiological classification of TIN, Tubulointerstitial Nephritis. They are divided into the two, infective and non-infective causes. Infections are mainly acute bacterial pyelonephritis or chronic pyelonephritis. The cause of chronic pyelonephritis is the tuberculosis, and some viruses and parasites leads to infections, acute infection that cause acute TIN. Non-infective causes are acute hypersensitive interstitial nephritis, analgesic abuse nephropathy, the patients who are using the long-term non-steroidal anti-inflammatory drugs in certain rheumatic uh, disease like osteoarthritis, rheumatoid arthritis. So these patients are taking the long-term non-steroidal anti-inflammatory drugs. Diabetic nephropathy also is the non-infective cause in multiple myeloma, that is called myeloma nephropathy. When the uric acid level is raised, that leads to urate nephropathy. Gout, again due to uric acid deposition, crystal uric acid deposition. Radiation, patients who are the cancerous condition and they require the radiation therapy, so these patients can develop radiation nephritis. Sometime in the rejection of kidney transplant patients, nephrocalcinosis and idiopathic interstitial nephritis. So the drugs has got important role that leads to acute TIN or chronic TIN. The commonest drugs are the non-steroidal anti-inflammatory drugs, penicillin, and in antibiotics, penicillins and cephalosporin, antituberculous drugs, rifampicin, and other antimicrobial drugs are sulfonamides, trimethoprim, and sulfamethoxazole. Diuretic has got important role that leads to TIN, like loop diuretic, furosemide, bumetanide, bumetanide, and thiazide type diuretics. Quinolone, ciprofloxacin can cause, and H2 blockers such as cimetidine and ranitidine. If you compare the cimetidine and ranitidine, so cimetidine only rare cases have been described with the ranitidine. Xanthine oxidase inhibitor drug allopurinol, which is used in the hyperuricemia, it also can cause the TIN. Commonly, you know the drugs omeprazole, lansoprazole, these are the proton pump inhibitors. Patients who were using the due to gastritis or gastroesophageal reflux disease. So long-term usage of drug this cause the problem. Indenivir and 5-amino salicylate, the mesalamine drugs also cause these problems. So the major causes of the chronic TIN or chronic interstitial nephritis. First we discussed the acute causes. Now the chronic, they are divided into the two portions. One, the diseases in which the kidney area macroscopically normal, and other, the disease in which the kidneys are macroscopically abnormal. Now first, drugs and toxins that leads to this problem, lithium and cyclosporin and tacrolimus, these are the CNI, calcineurin inhibitor drugs, cisplatinum, PPI drug. Then there are some metabolic causes that leads to chronic TIN. These are the hyperuricemia, hypokalemia, hypercalcemia, hyperoxaluria, and cystinosis. Heavy metals, lead, cadmium, arsenic, mercury, gold. Balkan nephropathy, radiations, and immune-mediated condition, SLE, lupus, Sjogren syndrome or Sjogren syndrome, sarcoidosis, and granulomatosis disease. Wagner granulomatosis or vasculitis also can lead to vascular disease, atherosclerotic kidney disease or transplantation, hematological problems. So now the other causes that leads to in which the disease but the kidneys are macroscopically abnormal. These are the analgesic nephropathy, chronic obstruction, hereditary problems, and infections. This slide shows the functional manifestation of the chronic interstitial nephritis. So, the kidney functions are affected. Deterioration of the glomerular filtration rate with slow onset, insidious onset. You know, tubular proteinuria, mainly less than 1 gram per day. If you see the difference between the glomerular proteinuria and tubular proteinuria usually non-nephrotic range proteinuria. Glomerular proteinuria usually nephrotic range proteinuria. Inactive urinary sediments means hematuria, cast cells are uh, not present, but inactive urinary sediments. These patients, if they develop CKD, chronic kidney disease, so patient become anemic due to erythropoietin deficiency. Tubular dysfunction, especially proximal tubular dysfunction, When this proximal tubular dysfunction takes place, amino aciduria takes place. Amino acids present in the urine, phosphorus, and as a proximal renal tubular acidosis and Fanconi syndrome. DRTA, distal tubular dysfunction, and type 4 tubular renal acidosis, that is called hyporeninemic hypoaldosteronism. Medullary dysfunction, in which the concentration power of kidney is lost. So that is the reason these patients are usually uh, non-oligouric. Urine output is good, but in spite of that, due to concentration defect, kidney functions are disturbed. Salt wasting syndrome, it is the condition in which the sodium is lost text in the urine, that is called salt wasting syndrome. The causes of the salt wasting syndrome are analgesic drugs or tubulointerstitial nephritis. So, are the CNS causes cerebral salt losing nephropathy, salt sensitive hypertension. So, this is the regarding the functional manifestation of the chronic interstitial nephritis. So, coming to the clinical features, these patients typically present with renal impairment, kidney function initially normal, but deterioration of renal function takes place. The drugs which leads to acute TIN, so they cause generalized drug hypersensitive reactions. They can present with a fever, rash, and eosinophilia. It is the characteristic feature of the hypersensitivity reaction. In 5% of the cases, uveitis, inflammation of the uveal tract takes place. Lymphocyte predominant, interstitial nephritis, blood vein photophobia. Majority of the patients are not oligogenic acute kidney injury because in these conditions the concentration power of kidney is lost. So that is the reason patient has got good urine output. This slide shows the clinical manifestation of drug induced acute AIN. Basically, this is the data were pooled from the different case reports, including more than 200 patients with drug-induced acute interstitial nephritis. But patients with AIN associated with methicillin therapy or with nephrotic syndromes are not included in this study. So, if you see the eosinophilia, which is present in the 40%, extrarenal symptoms, which is present in the 50%, mild proteinuria 55 to 60%, pyuria 60%, and oliguria 30%. But majority of the patients presented with the renal failure, 90% of the patients. Coming to the investigations, from urine analysis, urine DR, as in the first lecture we discussed urine analysis is the poor man renal biopsy. From urine analysis we can take lot of information regarding the tubular disease or glomerular disease. Urine analysis shows the isostenida, specific gravity same, and no active sediment, and the eosinophils which are present in the urine. So if you perform the renal biopsy, that shows the intense inflammation and infiltration of the tubules and interstitium by polymorphonuclear leukocytes and lymphocytes. Eosinophil may be observed, and renal biopsy has got role, either it is acute or chronic. because we can predict the prognosis and outcome of the renal problems, renal disease. So renal biopsy is performed either confirm the histological lesion to predict the prognosis of the patients, and third, make the management plan because either acute or chronic, because in case of acute there is the role of corticosteroid, and in chronic tubulointerstitial nephritis there is no role of the corticosteroids. If you perform the proteinuria, protein creatinine ratio, it should be less than 100 milligram per millimole, and in urine, red and white blood cells, but sterile pyuria. What is sterile pyuria? Urine is sterile, though if you perform the urine analysis, that shows the presence of the pus cells, but culture doesn't show any growth of the bacteria. That is called sterile pyuria. In the blood test, obviously we should perform the renal function test, CBC. In the CBC, eosinophil will raise, lymphocyte may be raised, and in the renal function, urea and creatinine electrolyte may be disturbed, and uric acid, and we should check also sometime calcium, phosphorus, and alkaline phosphatase. And in the urinary findings, eosinophiluria, presence of eosinophil in the urine. The original that studies, that is called methicillin induced acute interstitial nephritis, that shows the sensitivity of 67% and specificity 83%. So sensitivity is higher in patient with interstitial nephritis induced by methicillin or when they perform with the Hansel stents. So Hansel stent is the stent which is used for the detection of the eosinophil in the urine. Okay. Isoacinuria means same specific gravity of the urine and the plasma. Blood in the urine or RBC occasionally may be present. Sterile pyuria, white blood cell and no bacteria. Nephrotic range amount of protein in the urine may be seen in the NSAID associated AIN because sometimes non-steroid and anti-inflammatory drugs can cause the membranous nephropathy. If you perform the ultrasound kidney in these patients, that will be normal size kidney. This slide shows the eosinophilia in the diagnosis of the drug-induced acute interstitial nephritis. Basically, the data from the recent and large retrospective series that confirm the eosinophilia. The eosinophilia, it is defined by the presence of 1% or more eosinophil in the urine. So, various causes. The bar shows acute tubular necrosis with eosinophilia, acute tubular necrosis without eosinophilia, drug-induced acute interstitial nephritis without eosinophilia, and drug-induced AIN with eosinophilia. This is the renal biopsy that shows the interstitial inflammation, presence of the infiltration of the various cells, lymphocytes, eosinophils, mononuclear neutrophils. So inflammation takes place. Again, this shows the interstitial inflammation. Drug-induced granulomatous interstitial nephritis. Commonest is the tuberculosis or sarcoidosis. Now regarding the management, if you talk the management, because these patients can present with acute renal failure or with allergic interstitial nephritis. So we should always take the history. If there is due to causative factor is a drug, we should stop the drug. And steroid has got essential role for the it accelerate the recovery and prevent the long-term fibrosis. So high dose corticosteroid 1 milligram per kilogram per day, but in this patient it is given for short-term therapy, and sometimes these patients require short-term dialysis. So this is the last slide that shows the acute renal failure with the features of AIN, acute allergic interstitial nephritis. So withdraw the offending agent, the causative agent, causative drug, we should stop that, and supportive care and close observation. We should see how the patient behave, either improve or not improve. If improvement takes place, continue the observation. If no improvement in 1 week or rapid progression, so we should must think either it is a classic allergic AIN, so steroid is recommended. If it is atypical features, then renal biopsy is the gold standard to diagnose the various problems. The renal biopsy will tell us either patient has got classic AIN, classic acute interstitial nephritis. If it shows the classic acute interstitial nephritis, always steroid is recommended and immunosuppressive drugs. If the renal biopsy shows the granulomatous or other immune interstitial nephritis, again steroids and immunosuppressive drugs has got role to reduce these problems. And biopsy shows also the chronicity, fibrosis or scarring. If it is developed, that suggests chronic TIN. So when the patient develop chronic TIN, these patients develop the chronic kidney disease CKD, then treat these patients conservatively. Here there is the no role of the corticosteroid. So treatment of the CKD, as you know, the conservative treatment, fluids intake, output, salt restriction, low protein diet, and a low phosphate containing diet. So we should treat this patient conservatively. So this is the all about regarding the tubulointerstitial nephritis. So thank you very much.